And so today we're going to really focus on how we can support our providers with documentation and this understanding that it's not just paperwork, that really it is the foundation for everything that we do in our practice. It leads to quality reporting, it leads to appropriate payments, and just your revenue cycle in general. And we know that in the Inland Empire in particular, we have a very high population of Medi-Cal, a lot of FQHC models. And so the more detailed, compliant the notes are, the better the practice runs and reduces your risk of audit. So that's really the number one. And so let's talk a little bit about the documentation loop. Why does it matter so much? So first, it starts with documentation. We know that the providers note what was done, why it's medically necessary, what the particular plan is, all should be included. It really should tell the entire patient's story. And so that's going to be how you guide your practices or your physicians in looking at what's missing and explaining that everything in that, if there is any missing information, it downstreams to coding, billing, your quality, and that breakdown. And so you really want to think of documentation as the blueprint, because if it's off, if there's a missing pillar, a missing wall, it's going to be flawed. So coding is going to matter because that's how the visit is translated. The documentation is translated into coding, your ICD-10s, your CPTs, and your quality codes. And so the coders, if you're using, whether it's a coder, an actual person, or your EHR, they're only going to code what's documented, not what's implied. So think of, maybe your scheduled visit says, patients here for high blood pressure, but if it's not noted in the chart, you can't utilize that as a way to document. You want to make sure it's in the actual clinical note. And so if they're not clearly documented, they won't be coded, leading to that lost revenue and audit risk. And so we want to also ensure that that your coding is only as good as the details in the provider's notes. So they can't really make anything up. Neither can your EHR if they're also utilizing those automatic codes. And then finally, in billing, as part of the process, once you document and it's coded, it goes to the payer. And so if the codes aren't documented or they're incomplete, maybe they're mismatched, your claims are going to get denied, they're going to be delayed, or they're going to be down coded. That's another big issue that happens. And so you want to ensure that all of those codes are being captured appropriately, as well as your quality codes being captured. Evelyn, last week, she was on the call. I'm sure you guys met her. She heads the quality department for IFMC. And they mentioned that a lot of the physicians will be doing the work. They're documenting in the chart note, but somehow in the billing cycle, those codes somehow got removed. So those are things that you need to be really cognizant of and aware of in the billing cycle. And finally, your payment, obviously, reimbursement is based on what's documented and what's billed, not necessarily what actually happened, because again, you're painting a picture for your patient. So you want clean documentation, accurate coding, which is ultimately going to lead to fewer denials, faster payment. And if you are seeing a high delay or a denial, that is unpaid work that's just sitting there waiting to be collected. And so we all know we have good best practices for that. You guys are looking at these claims on a regular basis, but this is all part of that cycle. And obviously compliance. This is going to be super important because your payers have rules, right? Especially your Medicare, your Medi-Cal, HRSA has rules, and of course FQHC has guidelines as well, ensuring that documentation meets those compliant requirements. And poor documentation, again, is going to equal your audit risk. It's going to lead to recruitments in your practice. And specifically, if you're part of an FQHC system, you're part of a value-based care contract, they're also looking at your documentation to ensure that you have the time, the consent, that your diagnoses are linked. Otherwise, you're going to have financial penalties on those documents. And then right back to documentation, the loop is completed here. And why I added this is so important is because this is where you get to educate those physicians, those providers, your clinical teams on how to properly document. So if you do get a denial, don't just fix it. Show them what was done, show them how best practices work. Adjust those templates in the chart notes if you need to. That's going to be really important in this process for compliance, revenue cycle, health, and improvement. You want to make sure that you have that continuous improvement loop. And so let's talk a little bit about some of the challenges that your physicians are going to be facing. Remember that they're taught documentation from a clinical aspect in medical school. Absolutely, they are, but more just to keep the patient safe, not necessarily how it's implicated in the revenue cycle. So that's going to be a big, important part of this. And so the time pressure, right? If you're squeezing them all into 15-minute notes, visits, they're going to have a lot of limited time note taking. So maybe what we would do with our schedule when we noticed that this was becoming an issue, versus having a 15-minute appointment, we would have it be a 20-minute appointment, have the patient out of there in 15 minutes, and give that provider a little bit more time to document properly. So that's a way to combat that challenge. You've got your issues with missing HPI, missing medical decision-making within the note. Maybe the note isn't signed at all. That's going to definitely add to your challenge. You've got coding uncertainty. Remember that there's a guide for the evaluation and management. I used to have 2020, the beginning of every new year, I would laminate the E&M codes based on CMS guidelines, and I would just have it right up in the under the provider's computer. Open up the little door, they can just take a look, make sure that they're coding it right. It gives them that guide. And even my most seasoned physicians who knew this like the back of their hand, they were grateful for that E&M cheat sheet. And the reason why is because it just makes it a little less complicated for them, and it ensures accurate documentation. So that would be a great way, just one option to take a look at that. EHR limitations. We all know we've got them. Multiple clicks. Your docs are complaining about 45 clicks to get through one chart note. How can you support them in that area? We've talked about this before. Maybe going to your EHR plan and saying, hey, this is complicated. Will you watch, Dr. Smith complete his chart note and share some ways that he could be more efficient? This would be a great way to combat that challenge in your practice. And then finally, delayed note closures. When they don't close their notes on time, this is going to create a big billing backlog where you have no money for a couple of weeks and then a big check. That's not really the proper way to do business from an operations standpoint. So set the expectation, as difficult as it is, that you want the chart notes closed within 24, preferably to 48 hours max. That's the expectation that you want for your physicians. I would love to hear from you guys at this point. I've been talking for a long time. And so I want to hear what your common challenges are. What are you hearing from your physicians? Is it just too many charts? What's going on in your practices with these challenges? We have a lot today. Hi, Jackie. Hi, Janice, Veronica. Good to see you all.
Hi, good to see you back.
Good. Yeah, thanks. Yep, I was in Lake Tahoe. It was lovely.
Oh, nice. Good for you.
Thank you. Thank you. Highly recommend.
Oh, yes.
So
Beautiful.
yeah, any challenges with your docs and documentation?
You know what? We actually leave our afternoons open for all of that. So we'll see patients back to back in the mornings, just go, go, go all the way till 1 o'clock. And then we leave the afternoons for administration. So we try to keep that time open for them to make sure they're completed, to make sure they're closed, because that can definitely create delays in billing.
That is so nice. I know you're in
Yeah.
specialty, so it's
Yeah.
so nice that you have that ability to do that. That's a lot of time, and I'm sure your docs are super grateful for that admin time.
Oh, yeah.
But even if you have a busy practice where you don't have that luxury of closing in the afternoon, give them some time. Time, Jackie, is going to give them less, burnout. It's going to lead to better claim documentation, and of course, increase revenue in your practice. So
Yeah. Yeah.
yeah,
Definitely.
I love that you
I
give time.
I like that extension of the 15 to the 20 minutes just to give them time to get the, charges in, get or whatever else they're documenting, putting up to get it closed out. I do like that idea. Just pushing it
Yeah,
out
that's
5 minutes.
exactly. And then, whether they take the full 20 minutes with their patient or
Yeah.
not, that may happen. We know
Yeah,
that.
of course.
But at least they have a little bit of wiggle room so you don't backlog so much.
Yes. Yeah. Yeah. Well, thank you.
Good. Yeah, of course. Thank you for sharing. Anybody else want to share a challenge with their practices and documentation? All right, I'm not seeing any. Let's look at a couple of different examples. So this is very common. You're going to see, I just put this as an example because we met with the IHP scholars, and these are all students still in medical school that we're hoping that they stay in our region. And we wanted to teach them a little bit about how physicians get paid, and we really focused on documentation. So hopefully these docs will be coming up the pipeline into your practices. But they don't learn a lot about this in school. They learn from the clinical aspect. They definitely do, but they don't learn at the implications of how it works within the revenue cycle. And so they were all excited to hear about that part of it. And so we used these two side-by-side chart notes to give an example of a good and bad claim, if you will. So this one on the left, obviously, it's very vague. Acronyms for the diagnoses versus spelling them out. Very vague history. Patient feels okay. That's not very helpful. Their meds changed, but what? How did they change? What did they change to? Assessment is the same as yesterday, same as last week, last month. We don't know. And on that chart note, no time was spent or documented and no complexity. Then you have your physician note B, which is robust. It has more details, specifics on the changes to medications, more specifics to the assessment. Again, and then the difference for these two is obvious, right? One claim may be denied, too vague, while the other one gets paid. And it's the same patient, but the one on the right has a much broader picture or blueprint, if you will, of that patient's visit. And I know that this is chart notes, paper chart notes, and some of your practices do have seasoned physicians that are still writing in chart notes, and then you as a team are implementing them into an EHR. I know that's happening in some cases. And I know that you are working to try to create those more robust documents, but showing your physicians the differences can really help, especially in terms of the revenue cycle. Most doctors speak in that language. So this particular slide we shared in our Medicare audits webinar earlier this year. This is directly from CMS. So your Medicare, Medicaid, Medicare specifically, I believe, is this. 59.8% of the audits, the denials, the recoupments are due to insufficient documentation. So not enough, not accurate. And then it just goes down the line, but you can see the common denominator in all of those: medical necessity, incorrect coding, no documentation at all stems from how the chart note is documented. So it's really the foundation, as I mentioned in the beginning, of the entire revenue cycle within your practice. So super important, supporting our docs with documentation. So how do we do that? So they're not educated on these things. Clinical, yes, but the different levels, the whys, the why nots, the compliance part, that's where they're relying on us as a team to support them. So how can we do that? Well, we want to tee those physicians up before they even get in the room, set them up for success. Um, create templates that can support them. Make sure that those templates aren't too overcomplicated. Um, Encourage them to customize those templates. Dr. Frank Flowers is one of our leaders. He was also at that IHP dinner, and he could not stress enough that sometimes the templates and the HRs also cause an audit risk because they're using them too much or not customizing them enough. So that's going to be an important tool as well. Ensure that you're training and coaching your providers on the best practices. Don't just fix it for them because they're so busy. Show them what went wrong so that they can do it right and cause less burden on your admin staff, your coders, your billers. We want everybody to be working at the top of their game. And oftentimes what you don't know, you don't know. So you've got to share these things with them. I don't know. Do any of you guys use Scribes? I think some of you use Scribes. I know that I've heard that before. Or voice recognition tools. Anyone? I know that the Dragon softwares and those types where the physicians can just dictate in often can just be populated right into the EHRs, which are great. Again, they still require training. They still require human eyes to review. And so making sure that those are uploaded appropriately is going to be our role to support our physicians and our clinicians. Also making sure that there's dashboards to track when notes are completed, to review coding patterns. I've shared this before, but anything you put into your EHR, you can pull out of your EHR. So monitoring those reports and noting any red flags in the documentation is going to be very important, especially when monitoring quality. And then the biggest thing, which I always add this in, is educating, communicate with those providers, have regular feedbacks. We love our huddles around here. Make sure you create a safe space for documenting concerns. I'll share that I worked with an orthopedic group, a very large orthopedic group out in the desert. And some of their MDs were frustrated, I can say, with the lack of documentation from their extenders, their PAs and their NPs. And they would just complain to leadership, and leadership would try to work with the MPs and PAs, but it was a constant battle. So we just decided to put in a mentorship program for medical MDs to share best practices with the MPs and PAs. They made this a regular thing, and now they're like working so much better together. We need our PAs, we need our MPs to support us so that we can take care of the more complex, our physicians can take care of the more complex cases. Any challenges, or let's talk about how you're supporting your providers in any of these areas with documentation. I think that's what the point of this is to really share each other's best practices and learn from one another, not just me. And then, hi, Janice, good to see you.
Same. It's been a little bit since I've logged on, but you
That's
always
all
have
right.
such informative presentations. I'm like, I got to get back into it.
I appreciate you being here. Good to see you. Thank you. Carissa, I see you're unmuted. How do you support your physicians with their documentation? I know you guys have a great system.
Right now, because we are onboarding new providers, so I do have templates that I've placed for our new ones, especially the ones coming out of fellowship who are all new to the specialty. So I have templates. I really make sure that we're updated for us in the specialty with our the CPT codes and way documentation has to be done in the hospital. So we have a little bit of different guidelines on what really they see when we submit our charges, to the insurance. And then if they are denied, we have to make sure that the documentation is set a certain way, because they are very particular, especially when it comes to hospital, for us. So again, I just have templates that we have in place, cheat sheets, and just make sure that, I keep them updated as much as I receive my updates, that I'm always letting them know that, make sure that you're, not just copy and paste, not just, changing one or two sentences. You have to actually do a detailed note. So I've really kind of just, emphasize that that's what we have to do.
Yeah, so you're reiterating exactly what we're talking about today is that, yeah, and you're giving them a guide. You're saying you don't have to remember all of this. I'm going to give
No.
you cheat sheets,
Yes.
right? Yeah, so I think that's great. You're setting them up for success, you're explaining the whys, and you're giving them a guide. You're setting them up for success. Have you heard feedback that this is helping them compared to where they were before?
So yes, only because the majority of them are new. So yes, to them, any type of resources, any type of support, they're, willing to take, willing to, hear, implement it and make sure they're doing it. So it's a little different for me, like I said, because a majority of them are new, where they don't, I'm trying to show them the best practice way because they don't have the other habits yet. So
That's exactly right. And you're speaking exactly to my point from earlier that they're not trained in this.
yes,
They're relying on us, your leaders in your group at Carissa as a leader in your group to show how to do it right and the reasons behind it. So I commend you on that. For any of you that are already doing this work and supporting your physicians, remember they're taught to keep patients safe. They barely dive into this stuff. And so we are taught to bring in the revenue, right? And so it has to be a combined effort. So awesome. So I'm going to send, before we leave, and we're just about wrapping up, I'm going to send you off with some best practices, some quick wins that you can take with you. Maybe one or two of these have already sparked some interest, but let's just review pretty quickly here. So daily huddles, I love my huddles, but this is specifically to catch missing documentation. So maybe it's quickly with your physicians in the morning where you flag a specific chart that you saw that maybe needs a little bit more attention. You're looking at a high priority documentation. Maybe you're looking at the 215s for that day and you're reviewing those particular charts and reinforce the 48 or 24 to 48 hour closure. And again, this is to help bring revenue into the practice. So from that perspective, we've got making sure that you've got those standardized templates. Carissa mentioned it. You have something that guides them, especially when it's for these common chronic conditions. High blood pressure should have a template, diabetes, definitely, or whatever your specialty supports. These can include the HPI, not just the cut and paste, but have them there and then train them on making that unique to the patient with prompts, and especially quality prompts if you're in that space in your practices. Unsigned reminders, or automate those reminders for unsigned notes or encounters. That can probably be done with your EHRs, I'm sure, where they get a little note that says you have 4 charts that need review. Encourage them to be looking at those on a daily basis. We don't want to see weekly reports showing outstanding documentation because again, they should be done within 24 to 48, but things happen and things get missed. So look at those things on a regular basis. Your dashboards can also help set up alerts. And then finally get that feedback from them. If something's too overcomplicated in the HR, you need to know about it. If the documentation from the regulatory body is overcomplicated, ask questions. Maybe your physicians are like, why do I have to add so much of this language? Maybe it doesn't need to be that in depth. Your payers will also help guide you on these things. So you can talk about these with your physicians and gather their feedback. And then the pulse meetings, that can be during lunch, after clinic, or in Jackie's lucky case, sometime in that 1 to 5 p.m. admin time. Talk about these things so that it makes things easier moving forward.